Eric Zimmer, from the School of Medicine, Director of Leadership Development, and I welcome you to our second First Fridays Luncheon. We started this program last month with a mentoring program for the faculty, and this is a program today for all of the School of Medicine. And we're going to be looking at issues of health leadership, or leadership in the healthcare profession, from various perspectives. And so I've invited a panel here to talk to you. I'm going to ask each member of the panel to speak 5 to 10 minutes, and then we're going to open up to questions. To my far right is Mr. Ray Swartz, who works as a consultant with the Veterans Administration and is an experienced business leader. We have Dr. Howell, who is the Dean of the Nursing School here at Creighton University. We have Dr. Zetterman, who is the Dean of the School of Medicine here at Creighton University, and Mr. Russ Perry, who is Director of Pastoral Ministries at CUMC. So I think I'd like to start with Dr. Zetterman, if I may. He has some slides for us. You notice how the timing was just right. He had just finished his food. He couldn't protest. So.
Well, I thought I would prepare for you a top 10 list. Now, I suspect some of you still watch late night television. Maybe not all of you, but as I looked at leadership development, I thought about some of the things that I thought were important for each of us as individuals. And one thing that's very important to me is mentorship. And in fact, I'm pleased that we have one of my mentors here, Ray Swartz, who was at the VA with us when I was there. But I'll start with actually the other mentor that worked with Ray and I, and that is, get it to work. So much for the thing working. There it goes. Leaders are leaders are made and not born. Bruce Avolio, who Ray and Bruce were our mentors for leadership development at the VA, and Ray still continues to do that, and actually Bruce does it as well, although he's a little further away now than he used to be. But Bruce made this point over and over and over again. Lots and lots of people say, oh yeah, but great leaders are born. You know, think back to the Revolutionary War, think back to the signers of the Declaration of Independence. Those were the great leaders of their day. They clearly were born that way. It's not true. Maybe there's a little bit of it that goes along, but each and every one of us can be a leader in our own way. And I would submit, and I say this many times, in the School of Medicine, everybody has to be a leader because we can change things around us. And for example, the students may feel like there's no opportunity to be a leader, but in fact, we change the curriculum every year based on the feedback from the students in their leadership capacity and what they bring to us. Number 9, everyone can or should be a leader, and I've just said it. At every level of our life, whether we talk about our church, or we talk about our school, or we talk about our family, or we talk about interactions amongst our friends, we all should take advantage of being that person who can help others. And leader may be an incorrect word sometimes. Sometimes that should be mentor. In the first session, actually, that Father Zimmer put together last month was about mentorship, and we'll have more formal things along mentorship throughout the year. But everyone can and should be a leader. Number 8, love your life and what you do. If you don't like what you're doing, it's going to be very hard for you to be a leader in that capacity. For me, personally, I've told the students this many times. In all my years of being a physician, I've never, ever regretted my choice. There's not a day that I can think of. There were some tough days, and there were some emotionally challenging days, but I loved what I do. In that capacity, I at least now can form some of the basis of what I can then bring forward. Same's true of your family. If you love your family and what you do, you can be a leader inside of that family. You can help them develop, and as your children grow, can hopefully be that kind of person that you want them to believe you are. Number 7, believe in yourself. Same thing. It's exactly the same point. If you don't believe in yourself, you can't possibly bring that knowledge and activity to others. So you really need to, in preparing yourself and making yourself into that leader, You really need to understand and believe all of the things about you that are important for your future and for your life. Number 6, the first person you should lead is yourself. If you don't bring yourself forward and take advantage of the opportunities to do a better job, to be a better teacher, to hopefully be a better mentor, to hopefully be a better leader, you'll never be able to do it with someone else. I've done some uncomfortable things, and being a mentor, a formal mentor, is perhaps one of the most uncomfortable things I've ever done. And I've done it a couple of times with young physicians in other states. The company that I used to work for used that as a formal building block. My answer was, I don't know how to be a mentor. How do I do this? But in fact, you all have life experiences that you can help them with. You're not telling them what to do. You're helping them understand how to do the things that they're asking questions about. And so the first person you really want to do is get yourself ready to take on those jobs. And there are lots of opportunities. This is an example of an opportunity to listen to people talk about leadership development and how to get it done. Number 5, be committed to what you're doing. If you don't believe in what you're doing, you can't be a leader in what you're doing. So again, I'm very committed to my profession. I'm committed to a variety of social and religious causes, but I'm committed in the things that I hopefully am trying to bring leadership to. Number 4, be steadfast with self-discipline. When you read about some of the great leaders in the world, you'll often find that one of the things that gets them into trouble is lack of self-discipline. And I'm trying to think of which one of the big computer companies it was in which the CEO was just fired because it was at HP, because of the payoff to one of the employees with which he had an affair he shouldn't have had. This is the sort of thing that sometimes people get caught up in. And I wouldn't want to say that that person was arrogant, but arrogance is an example of something in which you need to be steadfast with self-discipline. No matter what your position is. I used to have I actually found it in my desk. When I went to work as the chief of medicine at the VA, in my desk drawer, and the guy that I followed was a personal friend, that basically said something to the effect of, every day there's somebody out there who will be delighted to take you down to the job you have. And that's the part about don't be arrogant in what you do. Try your best. Don't get yourself into trouble by doing things you shouldn't do. So be steadfast with self-discipline. Number 3, work in teams. This is a crucial issue, particularly for all of the students and house officers today. My generation didn't understand this. At least the physician generation didn't understand it. I can't speak for everybody else. We thought we were the captain of the ship. Well, you all know that the great problems that have happened in a variety of places have happened because nobody worked in teams. Perhaps one of the best examples I've ever heard, and some of the people in the room are too young, but in Tenerife there were 2 747s that ran together on a runway, and I think the death toll was about 600 people from that. The plane that caused the accident was piloted by who was the very best KLM pilot that they had, the very best. But he had a series of circumstances. He knew that if he didn't take off in the next 3 minutes, he was going to cross over the work time of his flight attendants, and he'd have to shut his plane down. And so he was anxious to get his plane in the air, because once he had it in the air, the flight attendants would have to work for another 6 hours. Second thing was, his co-pilot next to him said, "Sir, you're on the wrong runway." And he said, "No, I'm not." And he powered forward. And of course he went down, and there sitting at the other end of the runway was a 747. They ran together, and everybody died. We need to listen to our teams, and our teams are all the people around us. Those include the patient, but importantly, they include the rest of our healthcare team, our nurses, pharmacists, our physical therapists, anybody that you can think of in your team. Working in teams will make you a better leader. Why? Because you'll listen to the things that they teach you. One of the best things that clinics now do, and some very successful clinic physicians I know, they hold a huddle in the morning with all the staff, the lady at the front desk, the man at the back that does the checkout, the nurses, the techs, everybody. They get together and they go over their list of the morning as a team and go through the patients that are coming in, because those people invariably know something really crucial about that patient that the physician may not know. And so working in teams is really crucial, and something we have to figure out how we do a better job of teaching along the way. Number 2, Listen to your colleagues, to your team and your patients, because somebody in that group knows more about what the issues are with that particular patient, with that particular event, with that particular plane ready for takeoff than does anyone else. Now, number one, focus on your strengths. My strengths are said to be, you can believe this if you want, I believe in harmony, that everybody should get along and work together. I believe in a variety of things of importance. There's a whole collection of things that you can study, but you can actually determine your strengths. Gallup has run this for a number of years for a variety of people. You can actually buy a book called Discover Your Strengths. It's actually unimportant what your individual strengths are to me. What's important is the concept that despite my high school football coach who said I should work on my weaknesses, the real truth for all of us is we should develop our strengths and go forward and push those strengths forward and use them to make ourselves into a better leader. Because your weaknesses can't do that for you. Oh yeah, you may be able to make some of your weaknesses better, but they'll never be as important in pushing you forward as will be the strengths that you have out in front. So you need to learn what those strengths are and then utilize those strengths moving forward. So that's my top 10 list. Thank you very much.
Dr. Howell, I invite you. You can speak there or speak here,
Okay.
whichever you're more comfortable with.
Oh, well, I can do either. Thank you, Father Zimmer, and good afternoon to all of you. Delighted to be here, and Rowan, that was very nicely done. A lot of these things mesh real well. As I talk a little bit about the perspective of leadership from nursing. Now, I can go back to the ancient times, like the 1860s, with the founder of modern nursing. You may have heard of her, Florence Nightingale. A lot of her work epitomizes, I think, a lot of what you see in leadership and nursing today. She got a tremendous amount accomplished, but she did it through using networks, her ability to work through friends and influential people to get things changed in healthcare. So what kind of things did she get changed in healthcare? Of her work in the military in the Crimean War, when she got there, there was no dietary services whatsoever in hospitals. Through her work, we now have what we have as modern dietetics, where meals are provided for our patients who are hospitalized. Before that, it was whatever the family members or whoever brought in or you could scrounge up. Through her work, she was able to institute what we now consider as disability-type payments. If a soldier was injured in battle and was hospitalized, he never received any more pay. She was able to change that, so the British government instituted payment for soldiers who were disabled. We now have that as just common practices today. Through her work, which was predominantly through analyzing outcomes, she used statistics. She was a great mathematician. She used statistics to demonstrate how mortality rates can change based on preventative and other types of hygiene care. So it put into place not only sanitary practices that we now use to reduce infection and promote health, but it also added using statistics to analyze patient outcomes. That work was picked up in the United States by people like Ernest Codman and others that you'll learn about probably in your curriculum. So while she was the founder of modern nursing, she used her skills and influential people to get things changed at the policy level and healthcare as we see today. Now, when you look at the most recent Institute of Medicine study that was issued in October, one of the findings was that of all the people that could, and groups who have a voice in healthcare, those who have the most silent voices are patients and nurses. So in nursing, what we're trying to do is to continue to work in our curricula. All of our students for years have taken leadership courses. But what is it that is either part of who goes into our profession or how we're learning to communicate with one another that is reducing perhaps the influences and the contributions nursing can continue to make. There's 3 million nurses. That is by far the largest healthcare profession in this nation. And to utilize that workforce to begin to make the improvements in healthcare delivery is essential, and that was one of the major recommendations. Our work as nurses and physicians is very interdependent. We're all part of the team. And there are going to be times when it may be the pharmacist who is the best team leader, or the nurse, or the physician. But as we learn to work together and to build those skills, how do we communicate? How do we share language? How do we recognize what one another brings to the patient care scenario? Those are going to be the primary leadership skills we need. In addition to learning how do you communicate directly versus passively, how do you deal with conflict in a way that builds each other up and enhances resolution of issues versus further widening our differences. Not being so quick to dismiss, well, that's just so-and-so's opinion or personality, but really being able to stop the plane from taking off. We have marvelous examples of quality and safety work that we're all striving toward. I think having our first patient safety day, although I was out of town, that's a great step. And we're going to continue to work on our curricula, our leadership skills, and helping nurses and our profession continue to make those differences and to learn to be an active player in the design of the next healthcare system. So with that, I look forward to your question and continuing this dialogue. Thank you.
I'd like to introduce Deacon Russ Perry. I neglected to mention that he's a deacon in the Catholic Church.
Well, it's an honor to be here. I want to begin with a little history, and that is there was a Georgian named Zupashvili. We all know him as Stalin. He was a Catholic educated fellow, by the way. And he made a statement once that's frequently quoted, and that was, "The Pope? How many divisions does he have?" And I think that kind of gives you an illustration of the position or the power position of pastoral care in the healthcare industry. We really don't have a lot of power. And as I'd like to take issue with something that Ellie just said, and that's that pastoral care is a little lower on the totem pole than nursing is. However, we do, in fact, lead, and we lead in modern medicine because modern medicine is recognizing more and more the importance of the body-mind-spirit connection, and that the mind and the spirit are just as important to healing and health care as the body is. So in terms of our leadership is often, probably 100% of the time, by example. We show compassion, and we exercise our principal skill, which is listening with the patients. And as a member of the team, that's really the way we lead. It's been a fantastic experience. It came to me late in life. I really was impressed with Dr. Zetterman's hierarchy there, the 10 top 10, and I can see all of those. As a person who spent 24 years in the Air Force and never believed he'd ever have anything to do with the healthcare industry, I can tell you that situational leadership is really important. I can remember as an undergraduate at Georgetown going through the ROTC program, we had a session called Leadership Laboratory. And it was pretty easy. not a lot of effort made in that area, a little bit of research on leaders. But in the military environment, you do have some power and some authority. And as you move up through the structure, you develop a little more of that and a little more of that. And then you get to do less and less of what you really want to do, but when you ask for something to be done, it gets done, usually. And if it doesn't get done, there are consequences, immediate consequences. So leadership in the military is pretty easy. Then, late in life, I got involved in pastoral care, and you have really no authority at all. Your entire ethos is really involved in diplomacy and demonstration and leadership by example. So I've had some wonderful experiences here in the Creighton community, and I'm gonna identify Marcia. She started along with Cecile Zielinski a program called Spirituality in Medicine. Well, that's been a fantastic experience for me. I've had the honor of working with a couple of fourth-year medical students who are about to graduate. And what we do is, at the end of that program, we take 8 hours and escort them around the hospital and let them see firsthand what a pastoral caregiver does. And there's a lot of misconception about what a pastoral caregiver does. But what I've experienced from that is, here's somebody that is going to be going out into the world as an MD and proceeding with their career, and they realize, hey, this pastoral care stuff fits into the team. This is how I can utilize this skill, this scope of practice, this set of skills. And that fits right into what Dr. Zetterman said about, leadership is a team effort. And I think that's one of the things that I have attempted to emphasize over and over and over again at Creighton. It's, we're not here as some sort of adjunct. We're a member of the team. We're part of that interdisciplinary team, and we need to know what's going on, and we need to make our contribution to that team. And that's really the focus, I believe, of modern pastoral care. Thank you.
Would you like to speak from there or here?
I was going to stand.
Okay.
That is an advantage. Well, first of all, thanks. I appreciate being here, and I thank you all for inviting me. Two things we were talking about when we were discussing today with Father Zimmer was maybe a little bit about what leadership means, defining it, and then why it's important to healthcare. And those are two pretty tough questions to do in 10 minutes. But I thought I'd start out by giving you the story of a poor example of a leader. And this is a true story, and it's about me a number of years ago. And I'll try and relate it to the medical side so that you can resonate with it. But at the time, I was running a business. It was about $1.5 million in size. Large, complex organization like a university or like the VA. Many tentacles, many silos of excellence within the group that needed to work together. But we made a decision to invest in it, and we spent about $20 million to improve it because the business was not doing well. So we got the latest and greatest in IT and make sure we could get real-time data, very similar to electronic records, getting real-time information about your customer, the patient. We also spent a lot of time getting the right processes in place, very similar to getting the best MRI machines and best laboratory to support and get the results to complement what you're doing with the patient. The third prong was basically redesigning the flow, so we got minimum interferences. If you took your OR room, the new hospital, and plop it in the middle and have your supplies right there, the offices right there, and the prep right there and the ICU right around so that you quickly get around. So you had the best flow for the patient to get through. We put it all together, and we got about half the improvement that we expected. And I sat back and I said, I don't understand this. Scratched my head. And the bottom line was, when we thought about it, we didn't include everybody in the decision-making of that business. We did not bring everybody in that had all this knowledge within the organization. And so I sat back and said, how do I do this? I mean, I've got diversity of people. I've got different strengths. I have IT, I've got accounting, I've got, like you've got surgery, and you've got, your business side and so on. How do I do that? And that's how I ran across what Rowan talked about, which was Bruce Avolio's work in research. It's always based on data, on transformational leadership. And I encourage you to Google Avolio. And there's a lot of his books and so on, and read some of that, because it's really very easy to understand and very practical to what you're going through. So we couldn't, we didn't bring the people in, so we brought them in. We brought them as part of the process. And we worked together and practiced the behaviors we thought we wanted in the organization. And without spending another nickel, we doubled the performance that we were at within about 12 to 18 months. So that's what got me thinking about what is leadership when you're trying to run an organization. And I don't care if it's a hospital or it's a university or it's an insurance company. It all boils down to, how do you get people involved to take that ownership in the organization to succeed? So I thought about that, and I tried to pull a definition together. So what I had was, what does leadership mean to me personally is achieving organizational ownership. And that's important, organizational ownership. Because a lot of times you can get individual ownership. If I'm doing research in a laboratory and I'm developing something, if you come in the room, I turn my paper over, I'm not going to share it with you. That's territorial ownership. That's ownership. It does not help the institution. So from an organizational standpoint, how do I get that ownership? At all levels of the organization, at all levels within the organization. So what Ron was talking about, the input you get from students to the input you get from the staff that run the university. Through an environment, do that through an environment of transformational leadership behaviors, which we can get into later if we want to, that encourages, and this is the other part of the element that I found through experience, it encourages transfer of responsibility to utilize the talents of all employees in the organization. So that's delegating properly, that's leading up to the leaders of the business. And that is one of the toughest parts in driving the leadership through the organization, to make sure it is built into the culture and it can be institutionalized to go on as not leader dependent. Is doing that so that you encourage that transfer of responsibility. I told people that when I ran this large organization, at least 80% of the time, I was a follower. Because if I go out and get the best IT person, if I go out and get the best accountant, why am I going to tell them what to do? What I try to do is get all the oars going in the same direction of the boat so that we make progress, okay, and make sure that we all understand and agree what the strategy and mission of the organization may be. But a leader transfers that responsibility to the organization based on the skill set, and then I maximize the results of everybody within the organization. So that's my rough definition of leadership. And the reason, I thought just quickly, I brought some notes here. One of the reasons why I think it's so important to medicine today is, one of the things I found out, this is like our 6th year at the VA that Bruce and I have been working there. And by the way, it's not that they're dumb people. It's taken 6 years. It's because if you want to implement it into the organization, I can explain the theory of leadership and the behaviors, and you've heard that from me and from the other panelists very quickly. It's the implementation into the organization that's so important. And that's what takes time. But there was a university health system consortium that studied, it was all teaching hospitals, in 2005 this is, it talked about high-performing organizations. And the study group identified those things in quality and safety and so on, and different parameters that they said were high-performing organizations. The key attributes that they found was patient first, the engagement of top management. They were part of the process. They weren't aloof. There was owners at all levels. They cascaded accountability through the organization to the talents. Across-unit collaboration, which is what I see as an issue within medical field today, between doctors, sometimes it's between a surgeon and internal medicine, and nurses, and. So the collaboration part for a common goal, so if you keep, patient first is the focus, it helps bring that all in line. But each one has individual strengths that they have because of their specific skill and craft that they have. And we have to be careful that you work that pattern toward the common goal of the organization. So they had, unit collaboration was strong, and the priority was safety. So when they went through that, they said the key characteristics off of that they found was a shared sense of purpose. The leaders knew and articulated where they wanted to go. The leadership style, the transformational leadership, or the passion about service and quality and serving the patient. Accountability for quality and safety throughout the organization. It was important. Everybody knew that. Focused on results, evidence-based decision-making. And again, the collaboration between groups so that it's the best for the patient. So that's, I think, is the evolution that's going on very strongly in medicine today from what I see. Being driven by a lot of outside forces with the new medical laws that are happening. There's a lot of constraints being put on, and it is, I think, so important that physicians and people that support the physicians take a leadership role in these changes. Because just like we're talking about, nobody knows medicine better than the people in this room. So as from a leadership perspective, we have to step up so that we do the right things for the country to serve the patient in the future. So that's my quick summary, and I appreciate your patience and listening.
Thank you to all our panelists. It's important for us, I think, to note that there are a number of common themes, and a couple that I would point out is that in order to be effective as a leader, you need to be aware that you're working with a team, with a group of people. And it might be from below, it might be from above, but it's going to be working with other people. Additionally, there are a couple of mentions of Bruce Avolio's work. There's also going to be, we have available to the faculty and the students will be rolling this out in the near future, work with Strengths Quest or Strengths Finder through the Gallup organization. I think some of you have already been aware of this. And we also have, if you will, a focus on looking at the results, data-driven, moving forward to some sort of defining success by seeing that the goals that you're setting out to are the goals that you're reaching, and you can measure that in some way, whether that's in looking in pastoral care, nursing, medicine, or administration generally. All these things are themes that we think we've heard here. Now, I'd like to open up the conversation to all of you here, and now that you've a chance to hear our panelists and perhaps get some food. So if we have any comments or questions for our panelists, or just generally. Although you can't talk about Nebraska Oklahoma football.
Is there a curriculum that's being made right now to teach leadership among medical students? Is that what it's being thought about?
Well, that's Dr. Zederman going to mention that, deal with that, or I can. Because of the accreditation process, we're not changing anything in the curriculum this year, but as of next year, we'll have programs built up that will go into force.
Can I add a little to that? Because I think there's some Creighton residents, surgery residents that are part of this already. We've started a pilot program at the VA with Tom Lynch's team and Jason Johnny's, where we are taking surgery residents, and 3 times a week we have like 20, 25-minute leadership sessions, in which we go through. We have a curriculum on it that we take through, and we've been at it now about a year, and we keep adapting it. They're sort of like we tell them that they're our guinea pigs, but we're trying to gather the data, expose them. We do that before they go into surgery. We do it in short segments because they're so busy. But it is really starting to go well, and it's laying a foundation. So I think there's a lot of activities in that area at the university and at the VA and so on. And Creighton's participating at the one there at the VA. Real interesting note, today we had the nurse manager for the surgery floor join the team, and we discussed the collaboration between nurses and the physicians into such areas such as even communication, the paging system, because you depend so much on that as a way to communicate. So I think there's a lot of activity that's been going on here in the last several years, which will benefit here in the near future.
Yes, I was speaking just to the curriculum within the School of Medicine, but in talking with people around the universities, there's a lot of programs that are currently underway. And the School of Nursing, Dr. Lazur is working on leadership programs. Dr. Howell, we have programs coming out of the business school. With the undergraduates across the university participate in this Strengths Quest program that Gallup does. So there's a lot of resources available, and one of my tasks, if you will, or my goals is to help coordinate some of these endeavors.
And not directly to the medical school curriculum, but across the health sciences curricula, one of the things we would like to do is to expand the number of interprofessional courses. For example, we have some at the graduate level in School of Nursing, global health policy and finance courses, a variety of different courses that really are open to anyone and would lend themselves to developing skills and skill sets so that you can take a leadership role in policy and understand the cost strategies and the finance strategies of healthcare and to really influence the direction of healthcare. So I think as we look at ways to make our calendars and logistical issues work, there may be a way that isn't just a nursing course or just a pharmacy course or just a medicine course. They can be more broadly taken by students.
Dr. Lazur.
One of the things we talked about early on when we were first meeting, an excellent book for anybody to read is Heroic Leadership by Chris Lowney. I don't know if the students have been exposed to that yet, but it's an excellent book in which the Jesuit theorisms are really introduced to anybody's working with, and really bringing up the people you're working with and bringing them up to be leaders as well. And it's a great primer for understanding about the Jesuits as well and the history of it. But it's a great book, Heroic Leadership.
Heroic Leadership. Thank you.
Stemming off of this similar line of thought, it's been interesting to see from a medical student's perspective how little interdisciplinary work we get to do, even at the level of knowing what our colleagues are studying. I find it interesting to ask some of my PT, OT, nursing, dental friends what it is that they're studying at a certain time, so that when I'm either in a rotation, say next year, or as a resident, that I'll know this is what my colleagues know, or what they're specializing in, what they're able to do, what I can depend on them for. Is there a way that we can start to introduce that at a younger age, and perhaps be able to know this is what we can count on our peers for, and this is what will be my job at an earlier age, perhaps not even with a class together, but just some sort of a learn what other people know and interact in some sort of a team-building fashion. Is there anything like that that is in the works or that is currently available that I'm not aware of?
Well, I think he was talking about from your perspective. Okay.
Terry?
Yeah.
As a practical matter, the way the neonatologists round, when you round with us in the NICU for 1 week with the third-year students, we round in the most interdisciplinary manner. You don't need to take a class. Okay, you sit in a room. We don't walk bed to bed. That's when we round. Okay, and we sit in a room, and we have the nurses there. The bedside nurse comes in, whoever's taking care of baby Jones comes in. We have a pharmacist sitting there. We have the x-rays up there. We have a respiratory therapist. So we're in a room, we talk about the baby, you as a student, blah, 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 here's the baby, you look at your spiel, I'll nod my head, and then I'll look at the nurse and say, is that the right thing to do? And if she says no, you don't do it, okay? So, I mean, that to me is the most, I'm able to round on 25 babies in a short period of time, so it's advantageous to me, give the best quality care, patient safety. But you've got to have the bedside nurse. Occasionally have the chaplain if there's issues that we need, and social workers. But you get so much done in an organized manner. So that's just a practical way. Now, we lean totally on the nurses because they're the ones they're there 12 hours. I'm in and out, and they're the ones that can tell me don't go under feeding or don't do this, don't do that. 99 times out of 100, I do what they say.
Yeah, there's several places. It's not an easy thing to do, and by far the easiest place for us to do it with the medical students is at the level of the clinical bedside in the junior and senior year, and especially with the residents, and do it there. And I think what's more difficult is figuring out how to do it in the first 2 years of medical school, because I think it needs to start there, and I think that'll be our challenge for the next couple of years to build it. We could certainly do it in the simulation center. There's a variety of things that we could set up issues there. And in fact, simulation centers will be used throughout your life in medicine or nursing or wherever else, because you need to do it with OR teams, including surgeons that might be 50 or 60 years old to teach communication skills and a variety of things. But yeah, some of the best teams that I've worked with where a team was important was the transplant team, where on any one day when I made rounds, it looked like the entire waiting room was moving with us, because you had a surgeon, a hepatologist, a nurse coordinator, a floor nurse, a pharmacist, a clinical pharmacist, usually a couple of pharmacy students, invariably a series of residents and fellows, and sometimes medical students on that team. And then everybody had their role, so that, when medications were talked about, we want to start this medication. Of course, pharmacy played a major role in helping us understand interactions, what the problems were going to be, how we had to follow the patients, et cetera. But the important thing is, to me, more than anything else, is listening. I sat on a witness stand one time in a lawsuit against a hospital in which they tried to get me to, it was about a patient care issue that was about when a patient was able to get out of bed and do things on their own. And the simple answer was, in our team, that was the nurse's responsibility. The nurse would know better when that patient was capable of getting up and sitting in a chair, getting up and going to the shower, doing a variety of things than I was, because I saw the patient for 20 minutes a day. But the nurse was there for 8 or 12 hours in a shift and clearly understood those things better, and those things were far better left to it. Well, they were trying to get me to take a different course so that they could do something different. But the answer is very simple. Take advantage of the people who know more about it. And the neonatal ICU is a great example, because Terry's got nurse practitioners that are there for, I assume, a 12-hour shift. And so they know those kids, 24 shifts. So they know those new babies better than everybody else. So everybody has a role, and make sure that all those roles are listened to. And I would tell you the same is true of the chaplain. The chaplain has an enormous role, or the minister or whatever, in every hospital that I've worked in. The person that I missed the most as a senior physician was the night supervisor nurse. Because when I was a house officer, it was invariably a woman, and she saved my you-know-what more times than I could count, because she knew things that I had not a clue about, and I could rely on her to help me get through the night when I was the sole physician in the house taking care of patients, because she had an enormous wealth of experience and the keys to everything in the hospital, so that we could get the things that we needed. But, you listen to those people. That's the issue.
I'd like to piggyback on Dr. Zach and Dr. Zetterman's remarks. Probably one of the best experiences of pastoral care as a member of the team is the interdisciplinary rounds that go on. And we can actually play a very strong role in those. But the neat part about being in this pastoral care business is our instructors basically are the nurses. And we, as, beginning outside observers, see that what Dr. Zach pointed up, that the doctor is there maybe for 10 or 15 minutes, the nurse is there 24 hours a day. Maybe a shift where you're sharing it with somebody else. They know intimately what's going on with that patient, and oftentimes their attention needs to be divided from patient to patient. They have more than one patient to operate with. We can fill that gap often because the patient not only needs medical care, the patient also needs attention. And sometimes patients can be pretty obnoxious with their need for attention outside the medical area. That's where you can call in the chaplain. And I've had this happen many times. A nurse will say, look, I can't work with that person anymore. Go in there. And you go in there and establish rapport with this patient, and you can keep them calm. It's part of what we do. It's our part of the team to do that kind of work. I don't want to dominate the time, but another area that's been particularly rewarding is family conferences at critical times. I find that, and I don't know if any of you students have heard me say this before, but the doctors that know what to do will call us in to go in there with them. And what we can do is because we're trained in listening and observing, we can pick up on whether the family is really understanding what the doctor's saying. And if we see that, a lot of blank stares and fidgeting and all that, we can reiterate what the doctor said. We can say, now, doctor, what I hear you saying is, and you go over the entire spiel, and then the doctor, he or she, can come back and say, yes, that's exactly it, and they hear it another time. So they hear it 2 or 3 times, and eventually it'll sink in. And, just a few of the roles that we can play as a member of the team.
And I'd like to commend you for actually taking the time to ask what people can do and where they are in their program. That's wonderful. Right now, there is no easy way. There's way too many types of healthcare professionals, very, very minutely specialized, to include that in any curriculum, all of your. But one thing you might want to do is, depending on whatever state you go to practice in, to look at those state regs. Most of the kind of list of what they can do and can't do is usually at the first part, so you don't have to read the 90 and 200 pages of regulations. So they're usually kind of a quick overview. And look at some of the main things. Even at a national level, I read position statements and hear opinions and comments coming out of a variety of different healthcare professional organizations that misunderstand the roles of other healthcare providers. For us, a lot of times nurse practitioners, and the newest role, the doctor of nursing, is really a degree, doctor of nursing practice, you hear a lot of misinformation. So it's good. And use people like me as a contact. I love to talk to students. So, yeah, anytime.
Question, Doctor?
I want to raise some challenges for the idea of collaborative leadership that raise issues both sort of internally at health sciences centers, but also more externally for academic community partnerships. And these have to do with issues of trust, power differentials, cultural differentials, and actually conceptual model differentials. So internally, as we talk about collaboration among disciplines, each separate discipline, to some extent, as you know, actually represents a different culture, a different group of concepts, and there are significant power differentials between the different professions. And so, obviously, one important challenge is how to work across these differences and how to approach them. And at the academic community interface, we also have major problems, often typically talking about disadvantaged communities that have long-standing distrust, even stronger cultural divides. And we have a center that recently formed for promoting health and health equality that's an academic community partnership to try to address this. But the question is for y'all, is from a leadership point of view, how do we take next steps in trying to, work across these very significant chasms that have to be addressed for successful outcomes?
I'd like to start with that. Our educational process is called clinical pastoral education. There are 2 centers in town. One is at Nebraska and the other is with Allegiant. Unfortunately, Creighton did away with theirs years ago. But what we emphasize is that all people deserve the same respect and dignity that we give to everyone. So for instance, whenever we deal with patients, staff, relatives, family, we deal with them in the same manner. We treat them with dignity and respect, and we give them the same kind of service we give everyone else. And so we define that as compassionate care. And I realize that, a few instances of that maybe doesn't overcome, a history of being mistreated. However, I think that's a worthy goal, and not only just for pastoral care people, but for everyone that works in the healthcare organization. And again, that's an area where we can show leadership, because this is our focus all the time when we're dealing with anyone that comes into our hospital.
One of the things I'm optimistic about is patient-centered care, the concept. I believe that when we put the focus on the person or the community that is the recipient of all of our care, then that kind of helps bridge a lot of those divides. I know it sounds perhaps Pollyannish in some ways, but it really does. It takes the eyes off me, my role, to what does this person or this community or system need, and alters all the imbalances, I think. You look at what you can contribute.
If I can add to that, too, yeah. I think the behaviors we really didn't get into on the leadership model. Bruce's work basically is, if I had to sum it up, is how you treat people, whether it be peers or whatever. So that's a huge element in the collaboration to improve that. The other thing is that I always tell them is a lot of times it's because you don't understand each other's worlds, and you need to take the time to understand that. And many times it's the process, the work processes that drive people apart. In a complex organization, it's the rules that get in the way and they cause a personal conflict. So I always say attack the process, don't attack the person. And I think together then is deal with all that, is deal with data, deal with evidence, and that takes away the emotion and the individual conflict. Is make sure you know the goal, if it is patient-centered, what you're trying to get to, the end result. But deal with the facts, don't deal with it as an individual.
I would just add one more thing, and I'm going to relate something that I think Ray and Jason Johning did at the VA, as I understand, and that's leave your biases at home. I think that's where we get into trouble, and Ray said it very well in not compartmentalizing people, and that's pretty much also what Ellie said when she talked about not restricting people to just what you think they should have. The VA has a little project, as I understand, about using the nurse's aide or the health tech, whatever you want to call that person on the floor, to take over a role that I thought was unique, and that is they simply empowered them to talk to every patient that they were in charge of every hour. Now, most of the time in a lot of hospitals, that's the person that changes the beds, dumps the urinal, gets the patient up to the bathroom. But now they took this group of people and they said, I want you to go by and see every patient in your team, on your group, every hour, and spend time with them, talk to them, find out what's going on. They've reduced falls amongst the patients, which means they've reduced injuries amongst the patients, and importantly, freed up the nurses, the RNs, to do the things that they really should be doing in providing the care, really delivering care in many ways. And so, you can use all the people in many ways. But people can do more than what we have compartmentalized them as being. About 15 or 16 years ago, I worked with a man named Paul Elwood, and Paul was a wonderful guy who probably is the biggest healthcare reform person actually in the United States. He's now in his late 80s. Paul believed that we should not have licenses for people, but organizations should determine competencies in healthcare. That, in fact, it was possible to take an example I would use is there was a heart surgeon at Johns Hopkins whose tech was the one who actually did the procedures. It's a Blaylock procedure, if I remember exactly who the surgeon was. And they made a movie about it. This man was unable to go to medical school because of his ethnicity. But he was actually the surgeon that did the cases for which Dr. Blaylock became world famous. So, people have lots of competencies if we allow them to be used.
I was at Emmanuel when they introduced the hourly rounding program with the nurses, and they went from the previous month 20 falls to the following month 0 falls. That was pretty amazing.
Perhaps we might end with one final question.
I was just wondering, I feel like in my experience, at least it's safe to say that healthcare is a field filled with very intelligent and capable individuals who are often leaders themselves. Have you found that in being a leader in a field like that, you've had to adjust your leadership style? Is it different from other organizations that you work with?
I would let Ray answer that question for me, because I think he would tell you no.
No difference. The skill set, the crafts may be different. It's no different. It's people. I mean, that's the hard lesson I learned that I was talking about at the beginning. The collaboration issues you have, trust me, it's the same thing in the real world. No matter what business you're in, sales don't get along with R&D, don't get along with this. It doesn't matter. It's recognizing that and getting people to take that ownership for the betterment of the institution. Not for themselves, but for the betterment of the institution. So that Creighton is the best medical school there could be. The Creighton Hospital is the best hospital in the world, because I believe in it, and I'm trusting everybody in the organization to do that. Now, I just caution you, don't make that statement in a week from Tuesday to happen. It's a long process to build that into the culture. But things like this help start that, because you're laying the foundation, and it can take off in different spots. And it is a journey. But you'll be surprised. You'll be really surprised when you start driving the ownership and you support that, how much you will rally people, even if they've been there for 20 years. It really make an impact. But I keep telling people, healthcare is no different than every other business that's gone through a revolution. I'm not trying to undermine you in your business. You're a wonderful business. You save people. You heal people. But it's the same thing. It's getting this mass of people in the same direction, taking that ownership for patient-first care.
I find that in every area you are in our society today, one of the big problems we have is the respect that people show for one another. And that's, as he was saying, that's part of our society today. And if we're going to be effective in any endeavor, we have to learn to treat people with respect, no matter who they are, no matter what their background is. And I think that solves a multitude of problems.
The one thing that I think is unique about our business, so to speak, is the fact that, like most any service, you can't standardize some things. A lot of what you as the individual provider will bring is how much accountability and what you do in that particular context. So it won't be that we know that everybody's producing this set of widgets or this set of cars or whatever. You're going to have to be able to have a broad range of skills and expertise, because each of those widgets that are coming to you is very unique from the next one. The people are so different. So that's why the team, we really push. You cannot expect yourself to have every answer to every situation. So to have those abilities to draw from others is crucial, because we don't have a standard product that we're dealing with.
As we end, I'd like to note that for those of you who've been able to come here, thank you very much for coming. Thank you to our panel. I think that the discussion has been excellent, and we appreciate all the insights that you've provided for us. As we go forward through the next weeks and next months of the school year, I'll be sending out information on various programs that we'll be doing, including other First Friday luncheons. So I hope that you look and keep watch for those in your email box. And I'd like to invite you to give a great hand to our panelists.